I'm Dr. Ibtisam, consultant ophthalmologist in Al-Qasimi Hobbs Hospital. Let us start our cataract session, fields and pitfalls in premier lens selection. And let us start with our first speaker, Dr. David Chang, talking about managing toric IOL misalignment. Yes, please, doctor, you can start.
All right, thank you. We'll be sharing my screen shortly. And good evening. It's great to be here. I think the first premium IOL to talk about is always toric IOLs. And I'm going to talk about how to prevent and manage misalignment. These are my disclosures. We have so many different ways to mark the axis. And this is an important paper that was a correspondence in 2017. It's a Japanese study. They did 72 consecutive monofocal torics, which they marked at the slit lamp. And what was good is they took digital photographs immediately after surgery, an hour later, a day later, and then at months 1, 3, and 12. And if you look at the net mean misalignment at 1 year, they're able to determine that 28% of that misalignment was actually due to surgical misalignment, not rotation. In other words, you could do this when you look at a photo right after surgery compared to where the doctor thought the lens should be. 61% of that misalignment occurred during the first hour, again, between the photo right after surgery and then 1 hour later, and that's rotation. And then if you look at rotation after 1 hour to 1 year later, that only accounted for 11% of the net mean misalignment, which is another way of saying that if it's going to rotate, 85% of its contribution to the net mean was in the first hour. So this, I think, really speaks to the importance of digital guided alignment. Varion is one system. We use the Zeiss Callisto, where we import a black and white image of the limbal vessels into this computer called Callisto on the microscope, and it registers the limbal vessels nasally and temporally, and then displays the actual alignment. So the yellow line is the 180 axis, and then in this case I requested 90 degrees for the toric IOL axis. You can see that when you do ink marks and then do the Callisto, that often there is a up to 5 degree misalignment due to the inaccuracy and imprecision of the ink marks. And then this was further corroborated by this meta-analysis from China. It's a fairly small meta-analysis, 5 studies, but they showed that image guiding gave a better overall alignment and outcomes, which is confirming what we talked about. So what are my pearls for avoiding misalignment? Well, here I'm showing basically, let's see why this is not running. So I think use a non-dispersive viscoelastic, number one. And of course, I go behind the lens and remove it every time. I'm using digital alignment. You can see the Callisto here. I tend to push the lens nasally anyway, because that's how I align the optic with the visual axis. And I think nasal placement does improve the contact between the haptic and the nasal fornix. And then finally, at the end of the case, I leave the eye a little bit soft, as you'll see here, because overinflating it will often inflate the capsular bag. And finally, I do have the patient minimize walking and activities that first day based on that Inoue study that I showed you. Using this technique, my partner and I published this large series over a year and a half of 1,273 consecutive eyes. And about half of these were the Acrosoft monofocal, half the Technis. We used a digital alignment on all of these along with Aura. So this is the first large study reported using digital alignment so that we can really differentiate what was rotation versus what was surgical misalignment. And unless you use digital alignment, it's very hard in other studies to figure out how much is the rotation. What we found and reported was the Acrosoft platform was more stable, whether you look at 5, 10, or 15 degrees of misalignment, it was highly significant. When you look at lenses that were more than 10 degrees off, it was 3 times higher with the Tecnis Toric, and that was a doubling of our repositioning rate. Now, last year, we published additional data, or continuation of the study. We got many more monofocal lenses, but more importantly, we had started using the first EDOF's IOL, the Toric Symphony, and we had nearly 800 of these eyes. We had a few Toric restores. What you'll see here is the misalignment rates, and you'll see that it parallels the monofocal rates, which are in parentheses, versus the presbyopia correcting rates, which are not. Pretty much similar as you'd expect. But now if you look at who had rotation more than 10 degrees, it was very much higher with the, again, the Symphony versus the Restore. And let's look at what we've got here. We've got now data that says that, look at these numbers, 2,400 consecutive Acrosofts, 700 consecutive Tecnis Toric monofocals. And you can see that truly it's a threefold increase in the number of cases we had to reposition. Then if you look at the Symphony Toric, surprisingly, it's double that of the monofocal Toric. Well, the reason for this is that these patients expected good vision at multiple distances, and if there was residual astigmatism, we and they were much more aggressive about wanting to go back and improve this in the operating room by realigning the IOL. So this is the first, I think, large study showing a comparison of monofocal and presbyopia correcting, and the fact that the indications for repositioning the OR are stronger with a presbyopia correcting lens. Well, our work prompted J&J to modify and do a lot of work on how they could improve the stability of their monofocal toric platform. And this is the result. It's called the ZCU. This has completely replaced the ZCT, and it's a frosting on the peripheral edge of the haptic. They actually looked at 6 different factors and the combination of 2 or 3 of these factors, and found that one change alone improved that stability, and that's to frost the outer edge. This is not on the Symphony, but it is on the Toric Eyhance and the Toric Synergy. And you can see that this friction does improve the rotational stability of the lens. So this is one of those rare times when one of our studies actually prompted a change in the design of the lens. And I can tell you now that I've done more than 400 consecutive Tecnis Toric 2s, the ZCU, and the reposition rate is 1%. So it's on par now. It's just as good as the Acrosoft Toric. So, you know, kudos to J&J for addressing this. And this is important now because with the Eyhance and the Synergy, this tells us we can expect similar results in terms of rotation stability with these presbyopia correcting lenses. Now, what if you do have toric IOL repositioning? How do we do this? Here's a case where they had preoperatively a need for a Axis 40 toric IOL, ZXT225, and yet post-op you can see we've got some residual cylinder at 8 days. Well, it turns out with the intended axis of 40, the true axis is 180. So we go back and we repeat the topography. Yes, it does confirm that that is correct. And then we use, in this case, an online calculator that's free, astigmatismfix.com. And we plug in the data. And what we then find is that the ideal axis is, based on the data, 34 degrees. And what's nice is you can see that the current refraction and what would be predicted using vector analysis by rotating the lens, and it cuts my cylinder by 1 diopter. So we're going to rotate the lens. The best time to do this is within a month of the original surgery so that the bag doesn't grip the lens too tightly. And I go back and I don't use viscoelastic because I don't want to re-expand the capsular bag if I don't have to. I take advantage of the shrunken bag to give better rotational stability. So I'm just using topical, and I'm just nudging the lens around with my BSS syringe with this cannula. And I'm using, here's my Callisto marking, and eventually I push that optic haptic junction. In our paper, we reported, I think, 90 of these rotations. We did not have any complications, capsule rupture, zonular dialysis using this technique, but obviously you have to be very gentle with that. And there you can see the accuracy of the digital alignment. All right. So what did the results show? Well, you can see that I actually did this at the same time that we did the patient's opposite left eye. And in the left eye, I don't know if it helped. I put a CTR in, knowing that there was rotation in the first eye. And the outcome was excellent for both eyes. So we just simply took advantage of doing surgery on the other eye to do our rotation. So think about doing this sooner rather than later. And I think our results show that you can be and should be aggressive with rotating these lenses because it's basically an enhancement procedure, just like we would enhance a multifocal refractive outcome. Consider a CTR if the first eye rotated, although in our study we did not find that it made any substantial difference. So I'll stop sharing there. Thank you very much.
Yes. Dr. Sofon?
Yes.
You can invite the second speaker, please. Then
Yes,
we can leave discussion at the end, but because of Dr. Chang, he is leaving. If anybody has any questions.
Well, it's only a comment to Professor David, whether you are using the total corneal power and its axis, or still you are using the classical way. Because when you can look at all the studies, the use of the total corneal power to calculate the toricity of the cornea, and it reduces a lot the misalignment.
Oh,
so what's your opinion?
So we use the total K, which is from Callisto, but if you also use the Barrett formula, it will calculate
Barrett toric formula.
Corneal segments of what the best axis is. They're often different. So you go into surgery with 3 different axes, and then we use Aura to help us pick a tiebreaker.
Great, thanks. Great, thanks. So the
can I ask another question, please? Sorry,
Sorry.
One.
No, it's okay.
Dr. David, I don't know if you can share with us your experience with enhancements whenever you have long-term results with the undercorrection of toric lenses, whenever you have a residual of astigmatism. What is your preference and what is your, results?
Sure. Well, most of the time, the enhancement with the toric is changing the axis. So number 1 reason is post-op rotation. Number 2 is that you put it where you thought it should be, but your post-op analysis says, well, 10 degrees or 15 degrees different would give you a better result. And it's, in my mind, very easy to do. It's very safe. We do it in the operating room. And I think all of us should be pretty aggressive about rotating the lens because that's your best enhancement. If you simply didn't correct enough astigmatism or overcorrected and it's a problem, obviously you can do keratorefractive surgery. You can even do IOL exchange. But fortunately, with the Barrett formula, and these are all available online, I think we're all getting better results than ever before. We just have to get the lens aligned in the best position.
Great, thanks, Dr. David and Dr. Khalid. We need to save the time because we are already running. So Dr. Yassin Dawood, he will give us the peril and pitfall of advances in multifocal IOLs. Let us see. Dr. Yassin, again, the stage is for you.
Thank you, David. That was a great talk. Thank you so much. Always great to see you folks. I'll be talking about multifocal IOLs, and I know that David, in his talk, has done. He taught us a little bit about some of the multifocal IOLs. I don't know how many of us actually are still using the multifocals, the restores and the resumes in this day and age. As a matter of fact, if you probably trained in the last 5 years, you probably will be confusing something called the crystal lens with the crystalline lens because, that lens is almost not being used. So we've come a long, long way in these lenses. However, the lessons that we're going to be talking about really are applicable to the multifocal as well as to the newer generation EDOF lenses as well. So why do we need these lenses? Because the patients are now really desiring more near and intermediate vision, especially with a lot of spending time on our screens. I had a patient on Thursday who he's like a piano player. He likes to golf, he likes to go fishing, and he likes to play with his grandchildren. So he's like, what can you do for me? I want a lens that gives me everything. I said, well, there's really no such lens that's going to give you everything. And I cannot promise you that you're going to be spectacle independent, but we can do the best that we can. And then you have issues that you have to deal with these lenses in regard to astigmatism. What is the pupil size, especially with the multifocal IOLs? How about patients who have other pathologies? So these are the ones that basically were in present, the multifocal, the Restore, and the Tecnis multifocal, as well as the accommodating, which we probably don't, most of us don't use anymore, which is the crystal lens mainly. And then I know that Dr. Sofon is going to be talking about the EDOF lenses and the trifocal. I'll focus a little bit on the Trifocal Pan Optics. So this is the Pan Optics, and it comes in toric. One thing that it helps us to understand how these lenses work, or what they actually give you, which is how they split the light. The monofocal, you see, you get the full light for the distance, but then really it dwindles right as you get into the intermediate. The Restore with the multifocal, it would give you mostly distance. Right around intermediate, it had a little bit of light distribution going down, and then it gives you a little bit more near. The Pan Optics is actually going to give you distance, shorts. It gives you like about 4 feet, 5 feet, which is basically for us like 1.3 meters or so. It really reduces a little bit of its light transmission, but then it gives you decent intermediate and near. And finally, the non-diffractive, the Vivity, it gives you all the way almost to intermediate, but not quite to the near. I noticed that the patient that was presented, that David just presented, got a J6 near, which is what you probably would be thinking about. J6 to J, when you put both lenses together, you probably are getting like a J3. So the Trifocal Pan Optics, what are the issues with this lens? All of these lenses still have significant issues with higher order aberrations, mainly starburst, halos, and glare. And when you actually are looking at bothered very much, meaning like these patients probably may head to lens exchange, you're still talking about 5% starburst, 2.4% halos, about 2% glare. And what about spectacle independence? I feel sometimes understanding the background of these lenses will help us be better advisors and advocates for our patients when we do the surgeries. So what you look at is the fact that many of these lenses, really about 88% did not need glasses. The Symphony, 85%, independence of glasses. The Pan Optics, about 94%. So there's really no 100% spectacle independence for many of these patients. Why is that? Well, number one, accuracy of intractal lens calculation. So when you actually look, the Barrett is performing really, really well. If you want somebody to be spectacle independence, you probably are looking about the 0.5 diopters, which is about 80% of the patients. But within 1 diopter is 97%, even in the best calculations that we have. That means even with monofocal lenses, you're still having about 3% that don't see 20/40, and really about 80% that don't see 20/20. So we have to be cognizant and humble about, okay, what are our calculations? What's the pearl? Number one, I may be off target. What's the plan? I have to treat that accordingly. If I get a refractive error, what is my plan? Am I a refractive surgeon? Do I have a refractive surgeon that I can send my patients for PRK or LASIK touch-up? This, if you're going to take anything, this is probably actually what you probably want to think about. The monofocal, all the way to the trifocal, all the way to the multifocal, you have a decreased spectacle independence. The only problem with that decreased spectacle independence, the reverse is you will have increased dysphotopsias. So you get to choose the balance of the lens that works best for your hands. And somehow the companies have decided that the EDOF is a balance or somewhere happy medium in between. When we look at these lenses, basically you look at the patients and what happens with these patients regarding, are they satisfied with their vision? Are they dissatisfied with their vision? You see that up of 8% of patients after these lens implantations are actually dissatisfied with their vision. Did the quality of life improve? Again, 8% said, no, my quality of life did not improve by these multifocal lenses. How about starbursts, halos, glare? About 10% across the board, about 4 to 10%. Now we're talking about multifocal. We're not talking about the new generation lenses. So let's talk about this patient, and that we'll learn about the pearls.
So I am with this 51-year-old lady who is after cataract surgery.
This patient has diabetes. She has amblyopia. She has a Fuchs dystrophy for 3 years.
And they said I needed cataract surgery first, and they put in the Cataract lenses.
Cataract.
It cost a fortune. And they did laser surgery, and they promised, oh, you won't even need readers to read anything. Your vision will be perfect. No more glasses, perfect vision, perfect driving. And after the fact, I need readers, and the strong readers don't even work for computers and, you know, reading my phone. So I'm very disappointed because I felt like I was misled. It's a misleading situation to put you through cataract surgery if you don't need it.
So basically, this is a very poor choice. The lenses are actually not bad lenses. I implant them myself. But the thing is that you have to choose the right patient. Pearl number one before anything, is this patient a good patient? And we have to be advocates. We have to be honest with our patients. Am I looking for the best interest of this patient ultimately? And this is the public trust that was placed on us as physicians. So this is the patient. You can see her goutte with the Fuchs dystrophy. She has this two-line toric, and here you see the goutte. Is this a good patient? This is a second patient. Before she met me, she came in with 6 pages, single printed, all kinds of questions, all kinds of research. I spent about an hour actually counseling this patient. And about a week later, she comes back and she says, oh, I have 3 more pages of questions. This patient, no matter what lens you do, she's not going to be very happy. So she's probably best to send to Dr. Sofon, so you know, he takes excellent care of her. But you know, like, do you want to be stuck with this patient, right? So patients with type A personality, like the guy on Thursday, and the funny thing is that his wife said, wait, you're not type A personality. I am type A personality. The wife was telling the husband. I was like, well, neither of you is a good candidate for these lenses.
Yes.
He's like, well, I'm like, look, even if you pay me $100,000, please save your money. I cannot guarantee for you. But I think it's a great technology. So counseling the patient is really important. So number one, selection. Number two, know the limits of the technology. Number three, if in doubt, don't do it. Number four, under promise, over deliver. The discussion, a lot of chair time. Before surgery, it's expectation. After the surgery, it is complication. Then what do? Treat dry eye disease aggressively before your measurements and before your surgery. Treat the cornea pathology beforehand if the patient has basement membrane dystrophy, for example. Understand ocular surface topography. Does this patient has anything that is irregular astigmatism that they may not do very well with these lenses? Corroborate biometry data. Be very confident about what biometry data you're getting. And David talked to us about Aura and the other machines that he uses. And I think it's a great idea to have multiple machines to corroborate your data. Advise the patient to be patient, to have sabr, as we say. Things take time. These lenses and your adaptation takes time. And have a backup plan. Sometimes you need to do refractive surgery. Sometimes you have to do IOL exchange. This is a patient that I put myself, and you can see that in his regular eye, he's seeing lights like this, and this is his multifocal lens right here. You look at it when he sees at tail lights, this is headlights, you see that he sees a little bit of starburst, but this is what he sees in, you know, in the multifocal lens. This is the starburst and the halos. He's an artist, so he was able, this is headlight, tail lights, breaks. So you can see that these things are real. These things affect patients' lives, and we have to be cognizant of that. And of course, my time is up. So what does this patient get? This patient gets basically removal of the lens and just replacement with a monofocal IOL. Thank you for your attention, and I'm happy to take any questions or discussions.
Maybe we'll move on to the next speaker, Dr. Sofon Al-Bayati. Now, back to you, but as a speaker talking to us about EDOF, and let us keep the discussion for the end.
Yes. Okay. So good evening or good morning or good afternoon, everybody. I think that the time is different with David, with my colleague, Dr. Yassine. And I think that Yassine starts with the, just let them, this is the keynote EDOF. Okay. I think that we are here. Let me just share. Yes. Before that, I need to close this and start with the as usual with a comprehensive and up to the time. Give us the summary to what we need to and why we need to improve or open a new door for a new advances in the lenses. And I think that this door is open just for a reason, that to close the door of the post-op photopsia, or to close the door of trade-off. The trade-off means that the patient should compensate, because our patient, as Yasin said, they are not a patient. They don't need to be a patient. They don't have patiency. They need everything. So everything means that they need no symptoms post-op for photopsia, and they need a very good near vision. So excellent near vision. And that's, unfortunately, till now, with all my discussion, it's not available. I don't have any financial disclosure with any product will be present in this presentation. Now, what we mean by EDOF? Why EDOF presented an extended range of vision is now a new technology that can be considered to correct the intermediate vision, because the basic optical principle is to add negative or positive spherical aberration equal to 1.5, 1.25 at an IOL level, which means that 1 diopter or 0.75 diopter at the cornea create a single elongated focal point to enhance the depth of focus. On the contrary, to monofocal IOL, in which light is focused on one single point, or multifocal IOL having 2 or 3 discrete points, and contrary to the EDOF that has one elongated. This IOL should enhance intermediate and near visual performance while minimally affecting distance vision. And that's right. It's not affecting the distance vision, and the patient will not have photopsia. But actually, it will provide only intermediate visual performance. So why? The question is why these lenses that having negative or positive spherical aberration in the center cannot extend more than what they are in. Adding more aberration magnitude than 1.5 diopter spherical aberration might have a trade-off, that's what we are saying, which affect the distance vision performance, photopsia, more than a trifocal, even more than multifocal IOL. Overlapping of the percepted image with a dysphotopsia phenomenon. That's why a new concept appeared, which called the EDOF trifocal hybrid, the EDOF hybrid. Now, just go back, we will go back to the EDOF pure. What we have available is the Vivity, and from Physiol, we have IsoPure, and we have iHands. Now, iHands, they are saying, no, it's not an EDOF, but it gives around 0.5 an addition with a certain technology that they are not adding a negative or positive spherical, they are adding changes in the center. Now, returning back to the EDOF trifocal or hybrid EDOF. The hybrid EDOF, that's what we are saying, is the best label that can prescribe IOL combine multifocality with a low addition power to reduce the distance photopsia by adding EDOF technology, which doesn't have photopsia, spherical aberration, positive or negative, in a low magnitude 1.5, and reducing the power of refractive or diffractive according, or both the refractive, diffractive multifocality. And by this, we will have 1.5, let us say, for example, as in a simple example, 1.5 from spherical aberration, whether negative or positive, adding to it 1.5 from a refractive or diffractive. In this way, we will reduce, not eliminate, we will reduce the photopsia, and we will have a near vision better than pure EDOF. This is the aim. So new model of diffractive, refractive, multifocal IOL having reached a high standard of clinical performance, targeting decrease halos and glare and starburst, as Dr. Yassin said, by decreasing the near optical power in about 1.5 diopter for their technology, refractive or diffractive, substituting it by EDOF effect, spherical abrasion, in about 1.5, 1.25. So the total will be around 3 diopter at a level of lens in the eye, which equal to 2.5 diopter at the corneal level. And this is only in, unfortunately, in certain lenses. Though we will see what we have. We have hybrid diffractive, a new model of diffractive multifocal. I'm not seeing the titles because something hiding my issues. Anyway, the aim is to decrease the halos, as I said, the glare, by decreasing the near optical power, substituting it by an EDOF effect 1.5. And these are what we are calling symphony. So the anterior is, as it's shown by this diagram, it will show exactly the surface, all the anterior side having the spherical abrasion and posterior side having the diffractive plates. Now, if we will go back to compare, and this is a very important comparison between bifocal, which have 22 rings, and symphony that have only 9 rings, having almost a power that can definitely, I'm asking all the companies, all the clinicians from the company, those responsible for the power, that they are not telling me any issues related to the power of the symphony that can reach to the corneal level, which is, in my experience, around 1.5. And the trifocality, comparing the rings in 3, we have 22 in bifocal ring and 23 in the trifocal ring, while 9 ring in symphony. The compensate is by the spherical abrasion EDOF. Now, if we will go to hybrid refractive, sorry, sometimes I'm not seeing in a way that, hybrid multifocal refractive, here, it's a rotationally symmetric refractive multifocal IOL with a reduced central diameter design, the same idea, the same concept, with 2 distinct foci and 2 definite corrective zones for far and for near vision. A new type of refractive EDOF hybrid IOL involving a central spherical element surrounded by an outer refractive ring. An example of it is the lucidus. And this diagram shows that the lucidus, in its refractive plate with anterior spherical abrasion that reduce this refractive plate in the center in a way that it reduce or hoping to reduce the photopsia, and it gives around 2.5 diopter at the corneal level, and I have I'm using it more frequently now. Now, the third one is the refractive diffractive, and this one is an enhancement on symphony, and that's what we call the third part, which is the from thickness synerge. The synerge having anteriorly spherical abrasion and diffractive posterior, and the whole plate is refractive. In this one, we can reach up to 2 diopter or to the corneal level. It's still less than the lucidus. Now, going to do the lucidus, I'm here showing the movie how I did implant, and see this is the center of the spherical abrasion of the lucidus, surrounded by the refractive element of trifocality. So this is a refractive, not a diffractive. Now, let us go to this case or a conclusion for this. EDOF hybrid IOL, one can maintain the near, intermediate, and distance vision in the same quality of the retinal image with less near compared to multifocal, but with less halos and glare compared to a trifocal. Now, let us go to this case. Is a female patient having 73 years old, post-hyperopic LASIK. Both eyes. Patient want presbyopic treatment, and she insists that she don't care about the distance, she need the near. Now, that was the refraction pre-op. Plus 0.75 minus 0.75 at 4, minus 0.5 minus 0.25 at 172. Best corrected visual acuity was 0.8, 0.7. Halos 0.5, 0.62 total root mean square. Spherical abrasion, I'm concerned a lot about that before the corneal map, because that guide me to the type of the lens that I will select, and comma here 0.3 in the right, 0.4 in the left. And if we will look at the right eye, topography would show that there is a pseudo keratoconic in the center, which is the steepening of the center resulted from the hyperopic treatment, and the K rating max is the 46. Now, again, high order abrasions, total is not more than 0.5. And this is the left eye. Topography shows that there is a steepening, and this steepening is 48.09. And the total is the total high order abrasion is 0.62. Now, the option, which option that I could select to have a best issues for this patient? EDOF pure, both eyes with micro monovision, EDOF diffractive, refractive, hybrid, both eyes, right eye, trifocal, diffractive, multifocal, left eye, EDOF refractive, both eyes, trifocal, diffractive, multifocal. Really, actually, I went to and I was, remember what Yasin said. Well, I select the EDOF pure with both eyes, micro monovision. If in the discussion we will have more time, we will discuss what the micro monovision. But why I select that? Because this considered as a monovision, first, monofocal lens. And second, the micro monovision is that those patients, they will not withstand minus 1.75 in one eye and minus 0.25 in one eye. So here I reduce the minus 1.75 to minus 1, and the other eye was 0, and adding the EDOF add, which is around add 0.75. So in the right eye, she had 1.75, 1 from the myopia, 0.75 from the EDOF, and the left eye, she has plus 0.75 only from the EDOF. Great, thanks for all, and very sorry to be late.
Thank you, Dr. Sofon. Let us move to Dr. George Alio. I'm inviting you, Dr. George, to tell us about quality of retinal image in multifocal and EDOF lenses.
Hello, good morning or afternoon there. I'm very happy to be with you today, but not in Dubai, such a wonderful place. And I hope that next time we'll be able to meet together in this location. Sure. The purpose of my presentation now is to complete the information that has been already provided about this type of lenses that are called premium lenses. Now, open my presentation, right?
Yes.
I don't know why it is not being open.
So first, you are opening the Professor Jorge.
Yes,
you are opening the.
Yes.
Okay.
I am, but it's not allowing me. I think that you have blocked me.
Please, someone from the organizer.
Yes.
Please share, Professor Jorge.
I think that the previous speaker is sharing the screen, and meanwhile, I cannot do that.
Okay, yeah.
Okay, now it's fine.
Yeah.
Yes. Now that is perfect. Thank you very much, because it was the problem. That was okay. So now the purpose of my presentation is to illustrate to you about how to choose the best intraocular lens for your patients, about premium lenses, and indeed focusing in what is the new trend in multifocal EDOF and this type of lenses. First of all, let's be aware that there is a change in the paradigm in cataract surgery. Formerly, cataract surgery was performed to restore vision, but now it is much more and more demanded by the patients to be spectacle independent. And this is why we have been moving from what was just the cataract surgery practice to improve the vision to get not only excellent vision, but spectacle independent. This change of trend is clear is a change in paradigm in ophthalmology. This is very important. I was a subject of this paper that we published in Lancet 2 years ago, before the pandemic. So which are the essential conditions to get successful outcomes? Obviously, perfect surgery, minimal invasive, good indication. This has been said by Dr. Daoud as well. The target is symmetropia and spectral independence, but finally you have to decide with lens. And this lens should be adequate in terms of quality, but adequate in terms of performance. Basically, you have to identify whether the focus score of the core matches with the patient, and also the quality of retinal limits, which is a new concept from which you can really deduct whether this lens is going to be successful in your hands or not. So you need to know the outcomes before making the indication. So today we have this display of lenses with a diffractive, refractive, EDOF, and this is my classification for EDOF, and I will be later on focusing more on this. Type 1 for me is spherical aberration based, type 2 pinhole principle, type 3 low near vision arc, type 4 hybrid multifocal, and type 5 optical center modification, which are the enhanced monofocals. Diffractive lenses have a very good vision for all distances and strong evidence in favor, but causes contrastivity loss. Quality of vision might be a problem, and most of them are people dependent, and halos and glare are whatever model you use, unavoidable to some extent. My choices at this moment are these ones that I'm mentioning to you here, and these are the choices that I do at this moment. I use refractive lenses as well, and they provide good vision on all distances. Mix and match is very successful. They are people independent, very important. You deal with people pathology. Contrastivity is preserved in sectorial varifocal lenses, but they cause distortion in high powers when you manage lenses of more than 2 diopters or more than 1.5, and dysphotopsia as a consequence as well. There are my choices: the Aconex, Vario, and VarioMax. This is the main negative effect that we try to avoid in this diffractive and refractive, because all of them cause to a certain level this phenomenon, especially if refractive are more than 1.5 to 2 diopters. And then the new players EDOF that happened about 3 years ago to appear, and they have, as I mentioned to you, different models, and the different lenses have been masquerading what is an EDOF consequence while they are really multifocals. It's important because they don't create different focuses, but rather than that, they create a continuous focus that is, of course, dispersing the light, and as a consequence, in a certain level, you decrease and you degrade the quality of the retinal image of the patient. You have to be aware that not all the EDOF lenses are really EDOF. Many of them are multifocals with low power that should not be called EDOF in pure concept. This is an editorial that I published in the Asia Pacific Journal of Ophthalmology, in which I was defending which was the EDOF and which is masquerade EDOF, which indeed should not be considered as that. And I am going again to my modification. Those that are in red are really EDOF lenses. They are either based on spherical aberration, pinhole principle, or the monofocal plus lenses, the enhanced monofocals, while the low power near vision arc and the hybrid lenses are not EDOF lenses. They are lenses that try to decrease the photophenomena with more or less success, but they use multifocal technologies. The EDOF have good intermediate vision, but has poor near vision in most of them, has caused less spatial satisfaction in my hands, because the problem is that many of them, especially type 1, degrades the quality of vision, and the best at this moment in my hands are the vividity and the hands, and indeed this is important because the others, like the pinhole, are not in my hands successful because they decrease the peripheral visual field, and you can confirm this if you measure visual field at 60 degrees and not 30 degrees as the company is offering to you. So this is why we publish this paper, in which you will find all what is about the concept of EDOF and the different types that we have displayed. But the topic of my presentation today is how to select the lens based on the most important parameters. The most important parameters is how much light is lost, what defines the concentrative function, how much vision the patient will have, and both of them are defined by the quality of retinal image. You have to consider also one more parameter today, cost effectiveness, and indeed is something that all these much make the patient satisfaction and the doctor's success. This is a paper that we published in which we have defined for the first time the in vivo quality of retinal image, and that you see here different lenses cause different type of quality of retinal image measured by the PSF. Remember, the PSF is related to vision, to visual acuity, while MTF, that we have also an study on this, is related to contrast. So with these parameters, you can define which lenses good. Look at the SA60 from Alco monofocal. They have the highest ratio of strength ratio. But look at the multifocal diffractive LISA. They have almost the same, while the others are far away from this level. It's important to see that at the accommodative lens, the Lumina is as good as almost as the monofocal, while some of type 1, like the Mini Well, is very bad as far as the quality of retinal image is awful. Look here, just to point more in detail this statement. How is the SA60? The LISA 3, the SA60 is better in terms of quality of retinal image, and LISA 3 is very good. But look at the Oculentis, which is good as well, but it's half the amount of the LISA 3 and about a little bit more of the SA60. Now compare this monofocal with the multifocal LISA with this Iol lens, which is a Mini Well. You can really deduct that this lens is not going to work in the eye. The patients can be happy if they are very tolerant, but this quality of image is suboptimal and should not make your choice on this lens based on that. Look here again, if you compare this example of type 1 EDOF with a monofocal, how degraded is the image. And this is, as Dr. Bayati mentioned, if you try to induce modifying and manipulate the spherical aberration more than 0.75, no 1.5, more than 75, you degrade the quality of retinal image significantly, as you can see here in this Mini Well lens. As a consequence, you don't need contrast sensitivity because contrastivity function is different in each one lens. Definitely, those that with the best quality of retinal image, like the LISA 3, have excellent contrastivity. Those that have almost good, as well as the Oculentis, have no sensitivity loss, while the others, all of them lose contrastivity, including the Iol lenses, because of this problem, because of the degraded MTF and PSF that these patients will have. Part of this information is in this paper that we published in the European Journal of Ophthalmology. And finally, let me finish with the focus curve. The focus curve is not defined by any retinal parameter, but by the performance of the light distribution. Different lenses offer different type of light distribution, and you need to know which is the light distribution of your lens in order to know if you are going to provide the service to your patient and the patient will be happy or not. This the focus curve should be measured in adequate conditions, and this has been the subject of this paper that we published, in which you can see most of the focus curve of the lenses that are available today by an independent study. So which are my lenses, my favorite lenses? With diffractive, I use the LISA 3, which shows to be the best one. The Rainer 100 intensity and fine vision. I use refractive when I don't want to suffer any conjunctive loss, and I use a lot the Ocules Vario and the Ocules Plus 3, less this one now. And the EDOF, I use the vividity and the enhance because all the others EDOF lenses, especially type 1, are not causing a good quality retinal image, and as a consequence, I don't like them. You can see this information, this paper published in Eye and Vision, in which we analyze and we describe for the first time how to study the quality of retinal image in vivo, in real terms, with this technology. And you have also the second edition of my book, in which all this information is released as well. Remember that we have this course in our university in which we have over 500 hours of multimedia activities in English dealing with refractive corneal lens surgery, and I'm sure that junior ophthalmologists and residents will be very happy to follow this course, which is a non-profit project of my university with a university certified course. And I want to thank you very much for your kind attention. Happy to be with you today, but not happy not to be in Dubai in person. Thank you very much, my friends.
Thank you, Dr. George. Dr. Sofon, you can invite the last speaker. Dr. Sofon.
Assalamu alaikum.
Dr. Khalid.
Sorry for that, Dr. Khalid.
Okay.
Sorry, Dr. Khalid. The last speaker will be Dr. Khalid Arfaj. Will present how to achieve the excellence in the premium IOL.
Thank you so much. I cannot share my screen. Can anybody give me the chance to?
I think that Professor Jorge, he should stop sharing.
You can scan.
Okay.
Yes, now it's okay now.
Okay.
So is it possible now? You can see my screen now?
Yes.
Yes.
Okay, good.
Clear.
So without delaying the time, we are running out of the time actually, and I really enjoyed all of the previous talks, and some slides and even knowledge I will deliver in this these 7 minutes already delivered. We want just to conclude the most important things that was not mentioned during my presentation. I don't have any financial disclosures to mention in this talk. my objective is to just to know what are the premium IOLs, to why we need really the premium IOLs in our practice, and so the pros and cons of some premium IOLs, and lastly and most importantly is how to select your cases to optimize your results. Nowadays, we know the cataract surgery is a refractive surgery. So many times we are doing refractive lens exchange, and nowadays it replaced some of the corneal refractive, many refractive corneal refractive surgeries. So this important information optimize our knowledge. We need to enhance our knowledge about the premiums much more and more nowadays. Many patients nowadays know expect the best and excellent results, and even very residual refractive error might decrease the outcome among them. So we need to be very precise among these patients. We know the mobile phones, sports, computer work, socializing, and cooking and night driving necessitate the need of the premium IOLs. So we are having really dynamic range of vision, and we know the global prevalence of presbyopia in 2015 was estimated in 1.3 billion, and it will reach almost 1.7 billion in 2030. So and so far we are not offering, surgical and permanent options more than 1% of this number. So the market is really huge for the premium IOLs. We know the astigmatism prevalence. It's estimated from 15% up to 35% globally. So we need to tackle not all of these are necessitating the toric lenses, but the astigmatism is really prevalent among many of the population and patients having cataract surgeries. Previously, we are having many pitfalls and frustrating IOLs, but nowadays, as mentioned with the previous speakers, we are having really excellent results with the trifocal lenses as well as the extended depth focus IOLs. These are some the unsatisfied patients among the old generation of the multifocal lenses. Nowadays, we are having some sort of successful story giving these patients very satisfied results. And the European Society Cataract Refractive Surgery, they have done in 2016 clinical survey, and they revealed almost 43% among this survey, they target monofocal IOLs, and 57% target the toric lenses and trifocal lenses. So it is an increasing market among the premium IOLs, and I think it might even increase more and more in the coming years. So we are witnessing actually a revolution in the intraocular lenses, and one of the very premium lenses was introduced in the market, that is the Visual in 2010, and in 2013 and 14 was the Ataliza was introduced with a successful results. This is Leopard 7, and this is the Microsoft Panoptix, and the Reiner trifocal lenses and toric one. And lately we have the extended depth of focus, as mentioned about the previous speakers, and we have very promising extended depth of focus IOLs, that the Eyhance and the Vivity lenses, Vivity from Alcon and the Eyhance from Thickness AMO. Why we are really sometimes liking, the EDOF lenses? We have some ocular surface diseases like the very severe dry eye, we have some chromatic aberrations, we have some post-refractive surgery and RKs, and many of these patients are really interested in decreasing the dependence of reading glasses. And we know the EDOF lenses are really very forgiving, and it might be used in these type of lenses. We know the LASIK and RKs and some other lenses, and some even the decentration or even angle kappa, these EDOF lenses are really tolerable to the decentration and high angle kappa. This is the Lucidus. I used Lucidus, I have used Vivity, and I'm looking to use even Eyehance from thickness, and it might even give us some sort of expand our indication of the premium lenses. But that's what I believe, that can even replace some of the monofocal lenses market. So what's the dissatisfaction sources, or why we are having dissatisfied patients? These are most common dissatisfied causes: the photophenomena, residual ametropia, development of PCO, IOL decentration, inadequate pupil size and dry eye, and lastly the large angle kappa. As mentioned about the previous speakers, we are having almost 75% of patients are having some sort of halos and glare, but fortunately the disabling glare and halos is less than 10%. Residual ametropia is also is there, and it might result of inaccuracy of the biometric analysis and inadequate selection of IOL power, limitation of calculation formula, and I like Parrot formula. It enhanced very much the results, and some sort of error in IOL position, and sometime the IOL exchange or aligning the axis of the toric lenses might help. And if not, the corneal refractive surgery like the PRK or femtolasic might help in these cases. Inadequate pupil size is also one of the sources of dissatisfied patients. They give very poor near vision, and it increased the photophenomena very much. So you have to be very careful with the large pupil patients. PCO also very common in some lenses, even reported up to 30% in these trifocal lenses or multifocal lenses, and the capsulotomy shouldn't be done before the stability of the IOL more than 6 months post-op. Patient selection, as mentioned, and this is the very important step in giving the success story about the premium lens, and we need really motivated patient to give them these type of lenses, and they should understand the limitation of premium lenses and having a realistic expectation. So I mean 3 or 4 slides more in my talk. Please avoid giving the premium lenses generally for very high expectation patients, RKs, unless you might use some sort of EDOF lenses with micro monovision or mix and match in these cases. If you have high cylinder, please do the toric lenses for the patient. Avoid patients for very severe dry eye and cornea scarring and very large pupil or even large angle cap. This is my study about the visual outcome of and patient satisfaction of bilateral implantation of trifocal lenses, and we use the Arabic version, English version of visual function 14 questionnaire to do our results. And this is our results. Very, so far we implanted almost 1,300 lenses. I didn't yet do explantation. Satisfaction is very high, 90%, and most of patients will recommend it for relatives. Photophenomena is really high, up to even 70%, but generally not disturbing, and night vision dependence, like drivers, might be very much dissatisfied with these patients. Yes, we have some dissatisfied patients, but generally it is very promising results. And this is my conclusion. Implantation of trifocal lenses for cataract surgery will give minimal level of photophenomena, what might be having a positive effect on the performance of vision related daily activity and high level of post-operative patient satisfaction. Thank you so much.
Welcome. Thank you, Dr. Khalid, and thank you all the speakers. We'll open
Dr.
the stage
Abtesam,
now
can
for
you just allow me there is one message from Dr. Muhammad Al-Amri that we need to
Yes.
leave to Hall A for a guest speaker. So if you don't mind, just for all our attendees, that we can leave to Hall A, because there will be no any activity in Hall C and Hall B, only in Hall A for a guest speaker.
Okay, and the questions discussion, shall we stop that? Yeah.
No, we
Okay.
can continue. Just as an announcement that we need to go to the Hall A when we will finish the discussion.
Okay, then we'll open the stage for the discussion and questions.
Yeah. So I need to go through and ask Dr. Khalid for a few things, his experience with the Lucidus. I start using the Lucidus for the last 2 years, and with all monofocal. I'm using Vivity, I'm using Isopure and Eyehance, and I found that Eyehance is only a monofocal, and it's not giving me even the 0.5 that I need for the intermediate when I'm asking when my patient need intermediate. And Isopure, yes, with the miss and match, as you said. Vivity is yes with a miss and match, and this miss and match, it gives me a better result when the patient cannot withstand minus 1.75 in one eye, so they can withstand by defocus test -1 in one eye as a residual, and the other eye will be Imitrop. So the add of the pure EDOF, it will be 1.75 and 0.5. Now, what's your experience with the Lucidus for those patients that because what I can get from your presentation, that you are using EDOF in those patients that they have some corneal abrasion. So did you have an experience with those that they have corneal high order abrasions, and did you use EDOF?
Thank you so much, Dr. Sofon. I really enjoyed your talk and your very informative question and comments. I have very limited experience about EDOF generally. Lucidus is also limited on the 6 or 7 cases. They give actually intermediate vision much more than near vision. Most of my patients, they needed reading glasses actually to have good vision. Maybe, as you mentioned, our target was not as we should do. EDOF might, if you mix and match and give the patient the idea of having one eye is more than the other one, like what we do, like with the monovision monofocal lenses, like we target -0.5 or 0.75. EDOF might even give the near vision much more than expected. But we target, as you know, and as we know, 0.2 or even Imitropia. For the Imitropia or -0.2, I think the EDOF will not do a good at near vision. They might give very good intermediate vision, and they are very forgiving. They do have very minimal photic phenomena, and it might replace the monofocal lenses market if the price go down. This is what I see in the future. It might replace the monofocal, and it might give the chance for the patient to give less dependence on the glasses in some of the activities, but it never will replace the near vision. We hardly even do the trifocal lenses. They give near vision, but the EDOF might not do that. But the Eyehance, I don't have any experience with that.
Okay, Dr. Khalid, great, thanks for this nice reply. So if we will go to Professor Jorge Elio, he has an excellent study that been published, I think, a few years back for the EDOF, when EDOF started, and they did a clinical survey for each one in Europe. And I need to ask his experience with the use of EDOF hybrid, and this term I took it from his study. I depend on this on your study, Professor Jorge.
Excuse me, Dr. Sofon, we're already behind the time, and this next session, it will be within 2 minutes. So please, if you can conclude. Sorry for interrupting. We're already 10 minutes over the time. Thank you very much. If you can.
Great, thanks. Welcome. So Professor Jorge, in this 2 minutes, can you give us any?
No, there is no 2 minutes, please. We are already going. We have a guest of a speaker, Dr. Sofon, sorry. If one, okay, within less than 1 minute, please, Dr. George.
Okay, Sofon, don't worry. We can continue by email, and this is a good question. So, but we have since no time. Everybody is waiting for the next session. But we'll be very happy. Email to me, and we have a chat on that. Okay.
Hopefully.
Thank you.
Okay. Okay, Mike.
Thank you so much.
Assalamu.
Assalamu. Thank you, everybody.
We'd like just to announce that we will have a guest of honor of speaker in Hall A. So we are requesting all to join us in a Hall A. Hall B and C, it will be for 30 minutes. It will be no sessions. Thanks for all our speakers in this session. Dr. Yasin, Dr. George, Dr. Abtisam, Dr. Safwan, and Dr. Khalid. Thanks a lot. Thank you very much.
Thank you so
See you,
much.
inshallah.
Thank you.
See you.
Bye.
Bye.